This was a presentation given by Dr. Joe Veltmann on August 28, 2014, before 250 medical doctors in Guadalajara, Mexico, as part of a seminar entitled Using Genomic Testing to Improve Patient Outcomes. Okay, so we have come to the second part of the presentation, which is entitled Breast Cancer, BRCA1, BRCA2, ER Positive in Women, and How Genomic Testing Can Improve Patient Outcomes. In this part, we're going to be focused on ER positive or estrogen receptor positive breast cancer. One of the learning objectives of this presentation is to differentiate between the breast cancer which has a family history, which we typically refer to as BRCA1 and BRCA2, versus the sporadic form which has no family history. Estrogen receptor positive, or ER positive, breast cancer makes up about 75% of this sporadic form of breast cancer. We have known for some time that estrogen exposure increases a woman's risk of breast cancer. This was conclusively demonstrated in 2002 when all data from the Women's Health Initiative were analyzed. If you recall, the study found that women administered hormone replacement therapy had a significantly higher risk of developing breast cancer. We can now extrapolate that data to include the various forms of exogenous estrogen, birth control, a woman who's undergoing in vitro fertilization therapy, hormone replacement therapy, of course, and bioidentical hormones. And we don't want to forget that a premenopausal woman is exposed to endogenous estrogen every month. For some women, this source of estrogen can predispose them to ER-positive breast cancer, particularly if they have SNPs or single nucleotide polymorphisms on one or more of the estrogen detoxification gene pathways. More about this in a couple of minutes. There has been considerable controversy about the effects of different types of HRT on breast cancer. Are bioidentical hormones safer than HRT? Can the route of administration of a hormone, whether that be oral, gel, or tablet, make a difference? And how does exogenous hormone impact the gene activity in a woman's breast? The first research to answer these questions was presented at the 14th Annual International Menopause Society on May 2, 2014 by Sondervist and his colleagues, who looked at the type of HRT, that which was studied in the Women's Hormone Initiative, which was conjugated equine estrogen plus progesterone, acetate, versus estradiol plus micronized progesterone, and route of administration of these hormones on gene activity in a woman's breast. Of the 16 genes studied in the breast tissue of the women who took the WHI form of HRT, 8 of the genes expressed differently, whereas only 4 expressed differently in women who took the bioidentical preparation. For those that are interested in the materials and methods section, 30 women were in each of the treatment groups, and they were given 2 cycles of the different types of HRT and different routes of administration, oral for the WHI HRT and transdermal estrogen plus oral micronized progesterone for the bioidentical. Breast biopsies on each woman were performed before and during the 2 cycles of hormone replacement. The abstract did not identify the gene studies, so we will need to wait until the results are published in a refereed journal to assess which genes that they were evaluating. This preliminary data, however, indicates stark changes in gene expression in a woman's breast depending on the type and the route of administration of HRT. Most healthcare professionals are aware of how estradiol can increase cell proliferation and cancer via its ligand with the estrogen receptor on cell membranes, resulting in an upregulation of gene expression in the nucleus and mitochondria, along with modulating cell signaling agents. That's the right-hand side of this graphic. The left-hand side of the graphic is often overlooked, I'm afraid. It is the detoxification of estradiol, its metabolites, and their impact on cell proliferation, DNA adducts, and oxidative DNA. Perhaps it is believed that if estradiol synthesis is greatly reduced using an aromatase inhibitor, or if a selective estrogen receptor modulator like tamoxifen can interfere with the ligand between estradiol and its receptor, then that's sufficient. We believe that the left-hand side of this graphic is equally as important as the right, especially if a woman has genetic SNPs on one or more of the important genes involved in estradiol detoxification.